Hello everyone, my name is Ivonne Marriott, and today I will be presenting a PowerPoint presentation on my DMP project titled Improving Depression Screening in Primary Care. First, I would like to review my DMP project committee. For my DMP chair, I have Dr. Constance Bowen. As second reader from Faculty of Nurse 705 is Professor Jennifer Theo. And lastly, Pascal Paul, a psychiatric mental health nurse practitioner, as a community member. First, in the context of my DMP project in improving depression screening in primary care, I want to take some time to review some vital background and significance in context of this project. Depression is a significant global and national public health concern. Current estimates indicate that more than 280 million people worldwide are affected by depression, making it one of the leading contributors to disability across populations. In the United States alone, approximately 21 million adults experience at least one major depressive episode each year, highlighting the substantial burden this condition places on individuals, families, and healthcare systems. Depression is associated with decreased quality of life, impaired functioning, increased healthcare utilization, and in severe cases, suicide risk. Because many patients first seek care in a primary care setting, these environments play a critical role in the early identification and management of depressive symptoms. Patients may initially present with physical complaints such as fatigue, sleep disturbances, or other nonspecific symptoms, which can make depression difficult to detect without structured screening processes. As a result, primary care providers are uniquely positioned to identify depressive symptoms early and initiate appropriate evaluation and treatment. The United States Preventative Services Task Force recommends routine depression screening in adult populations, provided that systems are in place to ensure accurate diagnoses, effective treatment, and appropriate follow-up care. These recommendations emphasize that screening alone is not sufficient. Rather, screening must be supported by clear clinical pathways that allow providers to respond effectively when patients screen positive. This quality improvement project was developed in response to inconsistent depression screening practices observed within primary care workflows. Without a process, screening may occur irregularly, increasing the likelihood that depressive symptoms go unrecognized. To address this gap, the intervention implemented a structured screening approach using the PHQ-2 questionnaire as an initial screening tool, followed by the PHQ-9 when indicated. These validated tools are widely used because they are brief, reliable, and easy to integrate into routine clinical practice. By incorporating these tools into the workflow, the project aimed to improve early detection of depressive symptoms, facilitate timely referrals when appropriate, and support continuity of care for patients experiencing depression. Overall, this DMP project highlights the value of implementing a standardized, evidence-based screening workflow. Now that I've reviewed a bit of the significance and background, I want to review the literature. Depression is frequently underrecognized in primary care, particularly among vulnerable populations, such as individuals experiencing socioeconomic challenges, chronic illnesses, or limited access to mental health care. Because many patients present with physical symptoms rather than a direct emotional distress, depressive symptoms may go unnoticed without the use of structured screening tools. When depression is not identified early, treatment may be delayed, which can negatively affect patient outcomes, including worsening symptoms, impaired daily functioning, and reduced quality of life. The existing literature strongly supports routine depression screening in adult primary care populations as an effective strategy to improve early detection. Several evidence based guidelines recommend the use of validated screening instruments to assist providers in identifying depressive symptoms in a systematic manner. Among the most widely used tools are the PHQ-2 and the PHQ-9. These tools are brief, validated, and practical for use in busy everyday clinical environments, making them well suited for the integration into primary care. The PHQ-2 serves as a rapid initial screening tool, allowing providers to quickly assess for the presence of core depressive symptoms. When a patient screens positive on the PHQ-2, the PHQ-9 can now be implemented to further evaluate symptom severity and guide clinical decision making. Research also demonstrates that standardized workflows significantly improve depression screening performance in primary care settings. When screening is incorporated into a routine process rather than relying on individual provider discretion, screening completion rates tend to increase and the likelihood of identifying patients with depressive symptoms improves. In addition, studies highlight the importance of staff education and clearly defined screening protocols. When healthcare teams understand when and how screening should be done, consistency improves, and patients who screen positive are much more likely to receive appropriate follow-up care, including further assessment, treatment, or referral to mental health services. Overall, the evidence supports the implementation of systematic screening protocols within a primary care setting. Next up, we have our theoretical framework, which is the Plan, Do, Study, Act framework. The project was guided by the Plan, Do, Study Act, also known as the PDSA framework. It served as the theoretical framework for a quality improvement project such as this one. The PDSA was appropriate because it provided a structured, step-by-step method for testing and refining clinical practice changes in real healthcare settings. During the plan phase, the clinic reviewed its current workflow and identified gaps in depression screening practices. In the do phase, the standardized PHQ-2 and PHQ-9 screening process was implemented during routine patient visits. Staff were educated on the workflow as well. In the study phase, screening completion, PHQ-9 follow-up, and documented referral actions were evaluated using aggregate data. In the final phase, which is the ACT phase, the findings were used to determine whether the intervention was effective or not, and whether the process can actually be sustained or further improved. This framework was especially useful because depression screening improvement requires something practical and iterative change rather than a one-time change, and the model supported a systematic approach to improve depression screening and further referrals. Up next, we have methods, design, intervention, and evaluation. This DMP project used, as previously mentioned, a quality improvement design to address inconsistent depression screening in one primary care clinic. The focus was on improving screening for adult patients during routine visits by integrating a more structured and standardized process into everyday clinical workflow. The intervention involved implementing the PHQ-2 questionnaire as the initial depression screening tool for all eligible adult patients, and for patients who screened positive on that initial PHQ-2, the PHQ-9 was used as a follow-up assessment to evaluate symptom severity and determine the need for referral to a mental health care professional. To support implementation, staff received education on how to administer these tools, how to document results, and how to initiate appropriate referral actions. The project was evaluated using this PDSA framework, as mentioned previously, and aggregate chart audit data. Because the data was de-identified and reported in aggregate form, descriptive statistics, specifically frequencies and percentages, were used to measure outcomes. These outcomes included PHQ-2 screening completions, PHQ-9 completions, and documented referrals or follow-up actions, as well as positive screening results. This approach allowed the project to assess whether or not the standardized workflow improved depression screening practices within the clinic. Now that we've gone over the theoretical framework, methods, and design, it's time to take a look at our sample. The sample for this project included 32 adult primary care patients who were seen during the implementation period of the Quality Improvement Initiative. These patients represented routine visits within the primary care setting where depression screening could be incorporated into a standard clinical workflow. Demographic characteristics such as age, gender, and other identifying information were not analyzed in this project, as all data was collected in a de-identified aggregate format in order to protect patient privacy and to maintain confidentiality. Among these 32 patients included in our project, 24 completed the PHQ-2 screening tool. This resulted in a 75% screening completion rate. This finding suggests that the implementation of a structured screening workflow helped facilitate the consistent use of depression screening routine patient encounters. While the goal of standardized screening is typically universal completion, achieving a 75% completion rate during an early implementation phase demonstrates significant progress towards improving consistency within this practice setting. Of the patients who completed the PHQ-2 screening, 13 individuals, which is approximately 54.2%, screened positive. This indicated the presence of depressive symptoms and the need for further assessment. A positive PHQ-2 result does not diagnose depression, but it instead signals that additional evaluation is warranted using a more comprehensive screening tool. For the patients who screened positive on the PHQ-2, the next step in the protocol involved administration of the PHQ-9 questionnaire. This PHQ-9 allowed providers to assess symptom severity and to better guide clinical decision making. Of the 13 patients who required this additional screening, 11 completed the PHQ-9. This represented a total of 84.6% completion rate for the follow-up assessments. This high follow-up rate suggests that the structured workflow did help ensure that patients who screened positive received the appropriate next step in the screening process. Most importantly, all patients who completed a PHQ-9 had a documented referral to a psychiatric provider in the clinical record. This finding demonstrates improvement not only in the screening, but also in continuity of care, as patients with identified depressive symptoms were connected for further evaluation, treatment planning, or referral as appropriate. Overall, this result suggested that implementing a structured depression screening workflow using the PHQ-2 and PHQ-9 tools can improve both screening completion and follow-up actions in primary care settings, supporting earlier identification and management of depression. Next up, we have data analysis. As previously mentioned, descriptive statistics were used for this project, frequencies and percentages most specifically. This approach was appropriate because the data was de-identified and reported in aggregate form. It did not include individual demographic comparisons, so inferential testing was not suitable. The analysis focused on key screening and follow-up outcomes. This included the PHQ-2 completion rate of 75%, the proportion of patients with a positive PHQ-2 result requiring PHQ-9 follow-up, the PHQ-9 completion rate of 84.6%, and the documentation of referrals for all completed PHQ-9 screenings. Next, we have our results and analysis of those results. This analysis shows that the intervention is very feasible within routine primary care workflow and that it could be integrated into everyday practice. The standardized process involved the consistency of depression screening and referral practices, which is the main goal of this project. The results also showed a strong follow-up performance with PHQ-9 completion at a high of 84.6% among patients who needed it. And all patients who completed the PHQ-9 had documented referrals for a psychiatric provider. This suggests improved adherence to the standardized workflow and better continuity of care. At the same time, some barriers did exist. These included time constraints during visits, differences in patient engagement, participation, and the lack of automated EHR prompts, all of which may have contributed to missed screenings or incomplete follow-ups. Overall, the percentage-based outcomes support the effectiveness of the intervention while also identifying areas for future improvement. Limitations of this project. This project had several limitations that should be considered while interpreting the results. First, the project was conducted in only one primary care clinic, which means the findings may not be very generalizable for other clinical settings or patient populations. Second, the sample size was small, which limits the strength of the findings and reduces our ability to apply these results more broadly. Because of the limited number of participants, the outcomes should be interpreted as specific to only one practice setting. Finally, the implementation period was short, so the project could not fully evaluate long-term screening adherence, sustainability of the workflow, or even long-term patient outcomes. A longer project period and a larger multi-site sample would provide stronger evidence for the effectiveness and sustainability of the intervention. Up next are a discussion on clinical significance, facilitators' barriers, and unintended consequences. This project had important clinical significance because the standardized PHQ-2 and PHQ-9 workflow improved the consistency of depression screening, supported earlier identification of depressive symptoms, and strengthened referral and documentation practices in the primary care setting. Implementation was supported by several facilitators, including a structured protocol, validated screening tools, and provider engagement. These factors helped integrate the screening process into routine care and supported adherence to the workflow. However, several barriers did remain, including limited time during patient visits, variable patient participation, lack of EHR prompts, and increased documentation demands. An unintended positive outcome in this DMP project was a greater provider awareness and confidence in addressing depression screening and follow-up needs. At the same time, the added documentation burden may or may not affect long-term sustainability unless the workflow is further optimized or supported by an electronic health record system. Implementations for practice. Standardized depression screening is important because it improves the consistency of how patients are identified, referred, and documented in primary care. Instead of relying on inconsistent clinical judgment alone, a structured process helps ensure that patients are screened more reliably and that follow-up actions are clearly documented. Validated tools such as this PHQ-2 and PHQ-9 are especially useful because they provide an accurate, efficient way to detect depressive symptoms early and assess for severity. Their use supports evidence-based clinical decision-making and helps providers determine when additional evaluation is needed. This project also highlighted the importance of provider education and workflow support. When staff understand the screening process and the workflow is designed to support it, early intervention becomes more consistent. Lastly, our conclusion. The project showed that a standardized PHQ-2 and PHQ-9 screening workflow was feasible in a primary care setting and could be incorporated into routine practice. The intervention improved the consistency of screening, referral, and documentation, which helped strengthen the overall depression screening process. The findings suggest that the project supported earlier identification of depression symptoms and improved adherence to an evidence-based screening approach among eligible patients. This is important because early recognition can lead to more timely assessment and referral. Although barriers such as time constraints and variability in patient visits and engagement affected implementation, the intervention was still successfully adopted. Overall, the project demonstrated strong potential for sustained practice improvement in depression screening within primary care. And lastly, here are my references for this PowerPoint. Thank you.